All right, let's introduce our next speaker, Dr. Moon, to talk about gastroparesis management. Thanks, Dr. Moon.
All right, good afternoon, everyone. I am not too pleased to be following Dr. Bilal's talk, but I'll do my best here. First off, thanks to our course directors for the invitation to speak today. So today I'll be talking about gastroparesis management from a general GI perspective. I have no disclosures. And so for the learning objectives, first, I'd like to briefly review the diagnosis and pathophysiology of gastroparesis. And then secondly, I'd like to spend the bulk of our time really developing an approach to gastroparesis management. And along the way, we'll summarize some of the evidence behind our common therapies. So real quickly, first, diagnosis. So the gold standard test for diagnosis of gastroparesis is with a Nuke Med gastric emptying scan. And I know it's tempting when you get these to just kind of hop quickly to the results section, just think, is it normal, delayed? There's your answer. But just a quick reminder that even before jumping to the findings, you should be asking yourself a few questions. This is kind of a reminder that your diagnostic test is really only as good as its assumptions, right? And so here are a few questions that I asked myself before I kind of carry forward. First, what was consumed? And so the default at our center, at most centers that offer a gastric emptying scan, is to consume eggs and some toast. But for those who may have an egg allergy or are gluten intolerant, there's alternatives. And actually the schedulers, when they call the patients, they have a list of different medicines that kind of qualify, and they range the gamut. And so some may be asked to bring from home some yogurt, some oatmeal, things like that. But I think we can all agree, just kind of intuitively, that an egg sandwich is going to be a little bit different from yogurt in terms of the way that you kind of interpret the results of an emptying scan. So what was consumed is my first question. And this will usually be outlined within the body of the report. How much was consumed? So standard is about 120 grams of eggs, which amounts to about 2 large chicken eggs, and then 2 pieces of toast with some jam spread. But they consume all of it. They consume only half and then vomit up the remaining. And so obviously that's going to dictate the way that you interpret the results of the study. The entire time allotment, was that reached? And so the highest sensitivity is for a full 4-hour gastric emptying scan, but sometimes it's not feasible. Other centers will have a 2-hour test, kind of extrapolate that data, looking at the kind of half emptying time. Again, sometimes that's all you got, that's fine, but keep in mind that if that is the case, or perhaps you're at a center that they did get a full 4-hour study, but maybe hour 2, hour 3, they for whatever reason couldn't finish or complete the test. So be mindful of the entire time allotment, whether that was reached. And then lastly, this isn't always written in the body of the report, but it's something that I'm mindful of when I'm sitting perhaps in clinic, talking to the patient to review their gastric emptying scan results, is were interfering meds avoided, right? And so I think obviously if you're on opioids, you have to interpret that with caution, as well as some of these other agents that can impact your gastric emptying scan. And then lastly, a reminder that assuming all these are kind of met and you interpret the result, remember that not all delayed emptying is gastroparesis. And so you could have delayed emptying as a result of some sort of mechanical obstruction. And so cross-sectional imaging and upper endoscopy also do play a role in the diagnosis of gastroparesis to rule out a structural obstruction. All right, the pathophysiology. And so I like to think of gastroparesis, I think it bears a lot of similarities to achalasia in the esophagus, but it kind of just happens to be in the stomach. And so actually the same nerve is implicated here. It's the vagus nerve, kind of some of those more terminal nerve fiber endings that land on the stomach wall. But you'll see that depicted here in the lesser curvature of the stomach here. You see your vagus nerve. And so it's similar to achalasia. So you kind of first have this impairment in peristalsis, so kind of the impaired accommodation from the gastric fundus, the body or the corpus of the stomach having hypomotility there. And then there's also this separate impairment in the sphincter relaxation. And so the pyloric sphincter relaxing, or sometimes even if the pylorus is able to relax briefly, there's this concept of antroduodenal discoordination. And so kind of this lack of synchrony of the duodenum that's trying to be receptive to the food particle coming in, it's unable to kind of receive it. These two mechanisms likely explain the motor components of gastroparesis, the motor symptoms. There have been a few alternate mechanisms that have been proposed, which I think better explain more of the pain or sensory component of gastroparesis, which include things like visceral hypersensitivity, altered gut permeability, and gut dysbiosis. Common causes. So idiopathic currently is actually number one. I remember a time when diabetes was the number one cause of gastroparesis in our country, but really starting to see a lot of young, previously healthy patients get diagnosed with gastroparesis, but followed by diabetes. And then the remaining kind of in descending order, more rare kind of causes of gastroparesis will include things like post-surgical, post-infectious, medication-induced, in this sort of grab bag of other rare medical conditions, neuromuscular, autoimmune, vascular, your kind of connective tissue disorders. All right, so this is where I like to spend the bulk of our time. I'll talk about an approach to management for gastroparesis. I'll be largely referring to our most recent 2025 AGA guidelines that came out. Now, I like the guidelines, but I will say a little hard on the eyes. It's a lot of text, kind of hard to kind of break down. So what we'll do is we'll take kind of snapshots of each of their slides with a single slide for each part of their pathway here. So the first thing that you do when you diagnose with gastroparesis, the initial treatment option, again, a lot of text here, but the way I like to summarize or think about this slide here is really your low-hanging fruit interventions, right? So someone who has maybe underlying diabetes, you're going to try to optimize them, their glycemic control. They're on certain medicines that can impact their gut motility. You're going to obviously try to eliminate those where it's possible. Dietary intervention is always low-hanging fruit. Thinking about a gastroparesis diet where it's small volume, small particle, spaced throughout the day with low fat and low residue. They actually, interestingly, kind of include pharmacotherapies within this kind of first realm, but you'll notice that it's kind of more as needed PRN use. These are your typical just kind of antiemetics that may not be specific to gastroparesis, but might be worth trying or generally considered to be safe. And then lastly, you'll evaluate for and treat other concurrent conditions that might contribute to symptoms. When there's no improvement with this, and usually a lot of this first pathway, it's really done at the PCP office level. And then, a lot of times I'm still being mindful of these things, but a lot of my patients, by the time they come to see me, have already tried a lot of this. And so this is kind of where we come in, is thinking about our specific pharmacologic treatments for gastroparesis. And so our guidelines would suggest the use of metoclopramide or erythromycin. And I think you can see here the quality of data, not very great, but we'll jump in and talk a little bit about the data here. So the summary of evidence for metoclopramide. To date, it is still the only FDA-approved therapy for gastroparesis. And I think what you'll see here is a little surprising. As something that's the only FDA-approved therapy, the data is pretty limited and not very strong. And so to date, there have been 7 randomized trials for a total of about 650 patients. Most of these were actually done in the 70s and 80s. I think Reglan or metoclopramide was FDA approved for gastroparesis in 79. And it's really hard to compare across studies. A lot of these studies are designed differently. They have different endpoints that they're measuring. Some look at objective improvement in a gastric emptying scan. Others look at a symptom questionnaire like the GCSI, the Gastroparesis Cardinal Symptom Index. But there was one study that showed and reported on the objective improvement in the gastric emptying scan, and it was 56% for metoclopramide versus the placebo being 36%. And then some of these other studies that have looked at the GCSI kind of report their outcomes a little bit differently. They looked at this pooled effect size scale to the GCSI. And so you see the GCSI here. There's 9 different categories. It goes from 0 to 5 based on the severity of their symptoms. And so the best signal was seen in vomiting with a 0.91 lower rate compared to placebo. For nausea, you saw 0.24 lower. And then really across the 7 other symptom categories, really no significant improvement. And so, depending on kind of glass half full, glass half empty kind of person, I view this as not very strong, right? We're talking 0.91 for the strongest effect seen. And you see here is less than 1, right? So 1 takes you from across a category line, right? From mild to very mild or severe to moderate. And really the best effect we've seen from metoclopramide is 0.91 for vomiting. I don't know if this is surprising, but hopefully this kind of makes sense. Really, the best effect is for vomiting and not for nausea. So, Reglan really isn't, you shouldn't really think of it as a centrally acting antiemetic, right? It doesn't really bind at the nausea center of our brain, so to speak, the chemoreceptor trigger zone. It's really just having more of a kinetic effect as an antidopaminergic agent. And then the AE rate, probably not surprising to us, but not the most benign medicine. There was an AE rate leading to discontinuation in up to 5.6% of patients, and kind of can go even higher depending on the study you look at. I saw some studies quoting up to a 14% AE rate. Most of them are mild, but some can be pretty actually lethal, right? And so long QT syndrome, torsade certainly can lead to death. So not the most benign medication, but to date, the only FDA approved one. What about erythromycin? So Dr. Bilal just kind of spoke a little bit about erythromycin. The data is even worse. So to date, 0 placebo-controlled, randomized controlled trials. A lot of the thought behind erythromycin comes from the studies that Dr. Bilal actually quoted. And so it's a known motilin receptor agonist, and there is data supporting its use in upper GI bleeds to improve visualization and clear the stomach. And so that's kind of been extrapolated to gastroparesis. There is a single crossover trial that's looked at erythromycin versus metoclopramide. Very, very small, weakly powered study, N of 13. Here they did note a GCSI reduction of 0.81, pretty similar to what we just saw for metoclopramide, in that kind of 0.2 to 0.9 range. And then they actually reported no serious adverse events. But remember, it was only 13 cases. And I think from other prior studies, we have good knowledge that erythromycin also carries some risk. There's multiple FDA level warnings for hepatotoxicity, long QT syndrome, multiple drug interactions as a CYP P450 inhibitor. And so with all of this evidence in mind, the guidelines would suggest the use of metoclopramide or erythromycin, but there's a lot of language here about really evaluating for side effects, right? And so, at 4 to 8 weeks, kind of making a decision whether or not it's really beneficial to do in the long term. A lot of these studies that I just mentioned really were designed over like a 2 to 4 week time frame. So we really don't have great data for long-term use. And so a lot of language here, like, hey, if no improvement or the development of side effects, to move to something else. The next part of the pathway here is to consider, as part of shared decision-making, a host of other kind of off-label, non-FDA approved therapies. And so I won't actually go into kind of one by one all the evidence for these. I will say that overall the evidence is pretty weak here as well. You see the single plus or the double plus sign. But really, evidence aside, I think kind of my issue and a lot of the clinicians hopefully would kind of nod their heads at this is, evidence aside, which is weak, there's a lot of logistical barriers to getting a lot of these meds as well. And so domperidone, not available in the US, you have to get through a Canadian pharmacy. Prucalopride, kind of an insurance nightmare. You usually have to kind of order Linzess, Imatiza, a few other agents before you can get that approved. Aprepitant, similar thing. I'm actually a fan of aprepitant. I've actually had a really good anecdotal evidence of it working as a pretty potent antiemetic, but really has been studied in a limited dose frame in terminally ill cancer patients receiving chemotherapy. And so going by the studies, insurances really give you a hard time getting more than 3 pills, is which how most of the studies have studied this in a 3-day kind of burst. And so kind of difficult to get. I won't go through all these, but you could see even for like nortriptyline, and that's actually not hard from an insurance standpoint, but has kind of more of a niche use case with really pain being the primary symptom. And so these are things that you can consider, not first line, but understanding kind of the risks of some of the other agents, it made its way into the guidelines. If there's no improvement with pharmacotherapies, really, the next step is, as part of shared decision-making, to consider a few elective therapies. And so there's botulinum toxin injection, pyloric Botox. There's GPOM, and then there's gastric pacemaker. The data, we'll go into it again, kind of very low to low certainty of evidence here. And then the last thing that the AGA guidelines mention is this kind of standalone recommendation that there's kind of this knowledge gap and there's no strong recommendation for or against the use of surgical pyloroplasty or surgical pyloromyotomy. I'm actually not going to talk too much about gastric pacemaker today, just really kind of approaching this from the general GI angle. I wanted to focus to talk a little bit on Botox and on GPOM. I will say that the evidence is generally pretty weak, and then the ability to perform it really depends on your center and whether or not there are surgeons who perform it. All right, so the summary of evidence for pyloric Botox. So to date, there have been 2 sham-controlled randomized trials, around 50 patients total. The first trial showed no significant difference in symptom response versus the sham, and then no significant difference in emptying. So they actually studied both. Some studies will pick one. Even though it wasn't statistically significant, I think the response rate may be around where you would expect with some of these other therapies. The thing that caught my attention with these trials actually is the high reported benefit of the sham arm. And so kind of interesting, 56%, that's actually what we quoted as the response rate for metoclopramide, the only FDA-approved therapy. And in this trial, the sham reached that. So kind of interesting to me. And there's, only so much I got included in 20-minute talk. There's a lot that you uncover as you look into that trial. That's very interesting. A lot of questions have been raised about kind of the strength of the study design, the inclusion criteria, but I'll kind of leave that perhaps later for the Q&A. But for what it's worth, no significant difference seen. The second study showed no significant difference. They reported their primary outcome a little separately or a little differently with this pooled GCSI effect size. And this was a composite. And so I think the other one that I showed was, 0.2 to 0.9 as a single symptom-based GCSI. This was a composite, so you can kind of almost think about dividing by 9, I guess. But 6.1 versus 3.8 on the sham. So it was, it was better, but it was not statistically significant, that signal. For what it's worth, at least shown to be pretty safe, 0 adverse events across these 2 trials. Since then, there have been a number of other open label studies that have shown maybe a little bit more optimistic results, about ranging with a response rate between 50 to 77%. And the AE rate does remain pretty low, anywhere from 0 to 2.4%. What about the evidence for GPOM? So the initial sham control trial that looked at GPOM really got a lot of excitement, was the study that showed statistically significant symptom improvement, 71%, kind of the highest signal we had seen for the GPOM arm versus the 22% for the sham. Again, I'd highlight that again. Pretty interesting here. So that the 22% number for the sham compared to the 56% that we saw for the Botox. I'm a little interesting here. They did not see any serious adverse events in this initial trial of 41. Since then, we've had a host of other studies, a lot of excitement in the realm of GPOM, many of them published by Dr. Bilal, but a recent systematic review that looked at kind of 15 studies, almost 1,000 patients. The GPOM response rate was around 63%, and the AE rate was about 10.6%. So maybe just a little bit over optimistic on the initial trial, but still very good response, 63%. Maybe a little optimistic to think that it would be a 0% complication rate, but 10%. And I will comment, when you kind of look into these AE rates, 10% is 10%, but it's interesting how they define them. Most of these were not severe or serious at all, or led to discontinuation of the study. A very small percentage of them are the serious adverse events, but the AE rate in total is 10%. So this is a repeat slide, but I just kind of wanted to show. So let's kind of look at this again. So summary of evidence on metoclopramide. Kind of pay attention to some of these numbers. The response rate around 56%, a pooled effect size around 0.2 to 0.9, compared to a sham of 36%. AE rate about 5.6%. The Botox slide that we just looked at. Again, not statistically significant. Response rate around 38 to 51, maybe if you want to be generous, around 70% according to some studies. The pooled effect size is about 6.1 as a composite. So divide by 9, maybe about 0.4, 0.5. And then AE rate that's pretty low, 0 to 2.4%. And then the GPOM slide that we just looked at, 71%, maybe 60 to 70%, AE rate, around 10%. Now I know this is a crude exercise, so I know that all these studies are different. They have different endpoints. There's different ways that they measured. It's not really valid to kind of compare them in that way. But I think just from a crude exercise perspective, I do think it's a little helpful in terms of how I think about these interventions that are in my toolkit. And so I actually would like to make the case today, really to consider Botox injection. Remember the first part of the Hippocratic Oath is first, do no harm. And so I think a lot of times when we look at data in trials, we really jump quickly to efficacy, as we should. We don't want to offer a therapy that doesn't work, right? And I understand that. But sometimes when the results are in total generally pretty weak and the efficacy rates look pretty similar, I think it's fair to look at the AE rates. This is really important from the patient perspective. These are patients who tell you in your office that they eat a bite of food and they're in pain, right? And so I think the thinking about safety is something that I like to do. And so I would make the case that, we're looking at, here's a copy and paste of, the recommendations we looked at. For simplicity's sake, I just included these, but if you actually pull up the guidelines, any sort of guideline will individualize all these recommendations and the level and certainty of evidence. Every single statement in this guideline is a +1 or +2. Okay. So very low or low certainty of evidence. And so I think when you have a really weak, data weak kind of zone, it's fair to consider things that are not just fair, but I would implore us to think about things that are safe and potentially efficacious. And maybe this is just me venting a little bit. It's just I've come to see in my observations, kind of training here and practicing here, is that Botox gets a little bit of a bad rap. This is something that I employ in my practice. I've heard a lot from whether it's my colleagues or fellows saying, almost condescendingly, "Oh, you're the Botox guy." I mean, I think we all should be the Botox guy, at least to consider it, right? There's nothing difficult about this. If you can put an instrument through your channel and inject, it's something that you should be able to do. There's people I've heard who say they will not do it as part of their clinical practice, or like I said, fellows or even our techs and nurses in the room saying, "Oh, you're one of the rare people who do it." And so, on the surface, you could understand why, just based on the weakness of the evidence. But again, I think hopefully what I've convinced you of is that all the data is actually pretty weak. And so I think it's something that, and it made its way in the guidelines as part of shared decision-making, something that you should consider. So I'd like to end with kind of giving you my approach. This is going to be really similar to the AJA guideline that we saw, but maybe just a little bit of a simpler kind of visual. And so when I see someone with gastroparesis, again, the first kind of low-hanging fruit thing to do is to talk about diet, review their meds, treat the underlying cause. The next step I'll do is I will consider a short course of metoclopramide or erythromycin. Emphasis on the short. So this is not a medicine that I'm giving a 3-month supply of with 3 refills, not seeing them in a year. This is something that I'm giving a really short course for, 30 to 60 tabs. Make sure that they follow up with me so we can check to make sure that it's working and they're not developing side effects. If I intend to use it longer, which is rare in my practice, I'll make sure that we have an EKG on the file, in the past 6 to 12 months, make sure it's safe to use. A couple special considerations. I'll consider prucalopride if they have concurrent constipation and I'm able to get it. And then I'll consider a neuromodulator if there's pain. Then pretty quickly, I will think about Botox injection and GPOM. And I've lumped these two together. I do kind of think of them similarly. And I'll talk, very candidly with my patients, kind of like we did now in a briefer fashion, just kind of summarizing the evidence and explain that it's Botox injection is something that I can do. The GPOM, I'll have to refer you out. But it is something that I loop together and talk to my patients about. And then really as a last resort is when I'm thinking about, GJ tube, TPN, surgery, clearly have its role. If you have someone who's got a BMI 14, 15, certainly something you need to think about. But really, I view that more as kind of a last resort when necessary. But I think there's plenty of cases where there's kind of immediate contraindications to Retinol. I don't know if it's just me and my patient panel, but every gastroparesis patient I see is on multiple QT prolonging agents, multiple antidopaminergic agents, centrally acting meds, have allergies, history of seizures. And so not too uncommon. And so in these cases, I'll be pretty quick actually to offer pyloric Botox and GPOM. And I understand, and I'm very frank about the data for Botox injection being weak. But in a lot of sense, you refer to for GPOM. Currently we have just Dr. Bilal performing them at our center. It's a little bit of a wait. They have to wait to be seen in clinic, and then get it. And I think there can be a delay in care. I don't think it's unreasonable to consider that while we're waiting, right? Plus, a lot of these patients, you might be already getting an endoscopy to rule out a structural cause. I think it's very simple at the same time to explain that you'll be taking a look to offer Botox injection in the case that it helps. So my take-home points, remember this is a data weak zone. Remember the Hippocratic Oath and do consider pyloric Botox as part of your practice. And GPOM does have the highest efficacy, though it does carry some risks. Though, again, I think some of this is center and operator dependent. In a place where we're a high volume center and have expertise like we do here, definitely wouldn't hesitate to refer for GPOM, specifically in your kind of more refractory, moderate to severe cases. So thank you for your attention. I wrote questions here, but I guess we'll save them for the discussion time. Thank you.
Thank you so much, Dr. Moon. An amazing lecture there.